In this session, I'll be discussing diabetes and other endocrine disorders in pregnancy. I'm Dr. Olofimbi Babatunde, a senior lecturer from the Department of Obstetrics Gynecology, College of Medicine, Ekiti State University, Ado-Ekiti. I'm also a member of International Association of Diabetes in Pregnancy Study Groups, IAD PSG, and an executive director of Adolescent Friendly Research Initiative and Care, ADOFRIC. At the end of this session, you should be able to define diabetes mellitus in pregnancy with its basic physiology. You should be able to appreciate the classification of hyperglycemia in pregnancy with a view to distinguishing between diabetes in pregnancy, called DIP, and gestational diabetes, GDM. And you should be able to appreciate the various screening modalities for diabetes in pregnancy, and finally, the management of diabetes in pregnancy and gestational diabetes in pregnancy. Diabetes mellitus is the commonest endocrine disorders of pregnancy that is associated with high maternal and perinatal morbidity and mortality if not well managed. It has an incidence of about 3%. Maternal morbidity and mortality with fetal wastage from diabetes mellitus was unacceptably high until the discovery of insulin in 2019 and 1921 by Banting and Best. Diabetes mellitus is a clinical syndrome characterized by hyperglycemia due to deficiency or diminished effectiveness of insulin, resulting in disturbances of metabolism of carbohydrates, protein, fat, water, and electrolytes. What is insulin? Insulin is an anabolic hormone. Of course, a 51 amino acid polypeptide produced by the islets of Langerhans of the pancreas. Relative or absolute insulin lack results in increased glycogen breakdown, called glycogenolysis, and reduced uptake of glucose into cells and reduced cellular utilization, all resulting in hyperglycemia, which is essentially the cardinal manifestation of diabetes mellitus. There is associated increased lipolysis and protein catabolism. All these form the basis of cardiovascular, neurological, and musculoskeletal manifestation of diabetes, affecting virtually all the organs and systems in the body, especially and notably the kidneys, where it causes nephropathy, and the eyes, where it causes retinopathy. So, what is the current classification of hyperglycemia? You should appreciate the current classification of hyperglycemia in pregnancy. The current thing now, the new and broader concept in diabetes and pregnancy is hyperglycemia in pregnancy, which can be divided into, which has two main classifications. The current concept now in diabetes and pregnancy is hyperglycemia in pregnancy with two main classifications. So what are the two main classifications? One, diabetes in pregnancy called DIP, and two, gestational diabetes, otherwise known as GDM. The definition of GDM is evolving. Until recently, the accepted definition was any degree of glucose intolerance with onset or first recognition during the index pregnancy. Reviewed efforts have been made by different organizations and bodies to modify the definition under the broad concept of hyperglycemia in pregnancy. So, we are going to distinguish between diabetes in pregnancy called DIP and gestational diabetes. So, we start with DIP. What is DIP? What is the concept of DIP? Diabetes in pregnancy. Diabetes in pregnancy may either have been pre-existing or first diagnosed during pregnancy. It may include any of the following variants: type 1 diabetes mellitus, which is autoimmune based, and type 2 diabetes mellitus, monogenetic, otherwise known as maturity onset diabetes mellitus of the young, mitochondrial diabetes mellitus, and secondary diabetes mellitus. Advances in genetic screening have resulted in the discovery and diagnosis of mitochondrial diabetes mellitus and monogenetic diabetes, maturity onset diabetes mellitus of the young. Diabetes in pregnancy, any of these aforementioned variants may have been pre-existing before pregnancy or developed during pregnancy. When the level of hyperglycemia first detected by testing at any time during the course of pregnancy meets the WHO criteria for diagnosis of diabetes mellitus in pregnancy in the non-pregnant state, the condition is called diabetes in pregnancy. I repeat, for you should be able to appreciate the difference between diabetes in pregnancy and gestational diabetes. In diabetes in pregnancy, which is called DIP, any of the aforementioned variants, type 1, type 2, MODY, mitochondria, may have been existing before pregnancy or developed during pregnancy. When the level of hyperglycemia first detected by testing at any time during the course of pregnancy meets the WHO criteria for diagnosis of diabetes mellitus in the non-pregnant state, then you are talking about diabetes in pregnancy called DIP. So what are the criteria? Number one, fasting. When you have a fasting blood glucose of greater than 7 millimole per liter, or 2 hours plasma glucose of greater than 11.1 millimole per liter, or random blood sugar of greater than or equal to 11.1 millimole per liter in the presence of diabetes symptoms, then you are talking of diabetes in pregnancy. And this can be detected at any time as long as all these criteria, all these values are met. Then you are comfortable to make the diagnosis of diabetes in pregnancy. And all you need to make the diagnosis is just one of these values. Either fasting plasma glucose, or 2 hours plasma glucose, or random blood sugar, random plasma glucose in the presence of symptoms. And recently, the American Diabetes Association recommended a diagnosis using glycosylated hemoglobin. Anytime you are able to get a glycosylated hemoglobin value of greater than or equal to 6.5%, confirmed by repeat testing, it is sufficient to diagnose diabetes in the presence or absence of symptoms. What is glycosylated hemoglobin? Glycosylated hemoglobin essentially is a stable ketoamine formed as a result of the combination of when glucose combines with the amino acid terminal of hemoglobin A chain to form a base called a skin base, which subsequently undergoes some form of arrangement to give a stable compound called glycosylated hemoglobin, which essentially can be used to assess the level of diabetes control, especially in the last in the previous 3 months. So those are the criteria for the diagnosis of diabetes in pregnancy. Now, the second harm, how do we diagnose gestational diabetes in pregnancy? Because in the past, the two concepts were muddled up. So having known the various criteria for the diagnosis of diabetes in pregnancy, how do we diagnose gestational diabetes in pregnancy, GDM? When hyperglycemia detected during routine testing in pregnancy, usually between 24 and 28 weeks, does not meet the criteria for diabetes in pregnancy, it is called GDM. I repeat, when hyperglycemia detected during routine testing in pregnancy, usually between 24 and 28 weeks, does not meet the criteria for diabetes in pregnancy, it is called gestational diabetes mellitus. So, diagnostic criteria and glucose cutoff values of GDM have been proposed by various bodies and various organizations and professional bodies. Currently, the most popular and widely accepted are those criteria recommended by International Association of Diabetes in Pregnancy Study Groups, IADPSG, in 2010, and World Health Organization, WHO, 2013, now adopted by International Federation of Gynecology and Obstetrics, FIGO. So, As per the recommendation of the IADBSG and WHO, the diagnosis of GDM is made using a single-step 75-gram oral glucose tolerance test, now the gold standard. When one or more of the following results are recorded during routine testing, specifically between 24 and 28 weeks, or at any other time during the course of pregnancy, then we are talking about GDM. I repeat, GDM can be diagnosed at any other time during pregnancy other than between 24 and 28 weeks. But the best diagnosis is made between 24 and 28 weeks. So, when you are having, when OGTT is done, and the following glucose values are obtained at any time during pregnancy, then you are talking of GDM in pregnancy. So, what is giving the diagnosis away? When any of these values fall short of WHO diagnostic criteria for diabetes in pregnancy, outside pregnancy, then you are talking about gestational diabetes. So what are the diagnostic criteria for gestational diabetes? 1. When you have fasting plasma glucose of between 5.1 and 6.9 millimole per liter. So it falls short of 0.1 to reach WHO diagnostic criterion of greater than or equal to 7 millimole per liter. Or number 2, when 1 hour post 75-gram oral glucose load gives a value of greater than or equal to 10 millimole per liter. Or when 2 hour post 75-gram oral glucose load gives a value of greater than or equal to 8.5 to 11 millimole per liter. 11 millimole per liter falls short of 11.1 millimole per liter by 0.1. So all these criteria, they fall short of accepted WHO diagnosis of diabetes in pregnancy and outside pregnant state. So when you have any of these values that fall short of WHO diagnosis criterion of diabetes in pregnancy, then you are talking of gestational diabetes mellitus. So you could appreciate the distinction. So it does not necessarily follow that GDM must be diagnosed compulsively between 24 and 28 weeks. It could be diagnosed at any time of during the pregnancy, as long as the criteria do not meet the WHO diagnostic criteria for diabetes in pregnancy, especially outside pregnant state. However, FIGO has different recommendations with some subtle variations in the diagnostic criteria, depending on available resources at country level and local practice. So, what is the basic pathogenesis of gestational diabetes mellitus? Increasing insulin resistance usually begins in the second trimester and it progresses throughout pregnancy. Increased insulin concentration required to overcome the insulin resistance. The normal pancreas can adapt to these factors by potentiation of insulin secretion. When women with GDM have greater severity of insulin resistance, women with GDM usually have greater severity of insulin resistance compared to the insulin resistance seen in normal pregnancy. There is also impairment of compensatory increase in insulin secretion. Failure of pancreatic beta islet cell to meet increased demand leads to the development of GDM in about 2%. The remaining 98%, the hypertrophy and hyperplasia occurring in the islet cells of in the islet cell is up to a level that the level of insulin can overcome the peripheral resistance of the peripheral resistance to insulin. So beta cell production of insulin is unable to keep pace with diagnostic hormones of pregnancy in GDM. So what are the various screening modalities for diabetes in pregnancy? There have been various screening modalities existing depending on the setting in question and resources. However, I want to also appreciate the fact that no single screening test has been shown to be perfect. I repeat, no single screening test has been shown to be perfect. So, what is the first line screening? First line screening has to do with detailed history taking and examination of the patient with a view to looking for features of potential diabetes. What are the features? Family history of diabetes, previous history of gestational diabetes, history of fetal microsomia, family history of diabetes, persistent glycosuria in the index pregnancy, previous history of unexplained stillbirth, and so on. There's another screening test called Lean test, in which when you have a random blood sugar value greater than 5.8 millimole per liter more than 2 hours after a meal, or greater than 6.2 millimole per liter within 2 hours of a meal, then that calls for full oral glucose, full glucose tolerance test, that is OGTT. So, the third screening strategy, which I would say is the gold standard, that is commonest, which is in vogue now, is mini glucose tolerance test, otherwise known as O'Sullivan glucose challenge. Mini glucose tolerance test, otherwise known as O'Sullivan glucose challenge. How is it done? When you have a plasma glucose level of greater than 7.7 millimole per liter 1 hour after injection of 50-gram glucose meal, it is an indication for full glucose tolerance test. Following an injection of 50 grams of glucose meal, 1 hour measurement of plasma glucose with a value greater than or equal to 7.7 millimole per liter calls for oral glucose tolerance test. Currently, there is this concept of universal one-step screening and diagnosis strategy, which is essentially a consensus of WHO, IAD, PSG, and FIGO. So, in which the screening and diagnostic tests are done all at a time in the same all at a time in the same test. So, what is the significance of diabetes in pregnancy? What is the significance of diabetes in pregnancy? Why is it important? Pregnancy adversity affects the control of diabetes mellitus. And number two, diabetes in turn adversely affects pregnancy. I repeat, the significance of diabetes in pregnancy is twofold. What are the effects of pregnancy on diabetes? And how does diabetes adversely affect pregnancy? Number one, what are the effects of pregnancy on diabetes? Pregnancy is a diabetogenic condition characterized by insulin resistance with a compensatory increase in beta cells response and hyperinsulinemia. This brings about the following conditions. Conditions that make the control of diabetes very, very difficult. The conditions that worsen diabetes. So what are the various conditions? We'll just give the synopsis. Number one, there are changes in intermediate metabolism in which there is post-receptor resistance to insulin. Peripheral utilization of insulin is dampened by these diabetogenic hormones. So what are these diabetogenic hormones? Human placental lactogen, cortisol, even estrogen, progesterone, human chorionic gonadotropins. So all these, they are antagonistic hormones to insulin. So they tend to dampen, they tend to prevent peripheral utilization of glucose, antagonizing the work of insulin peripherally. Number two, there are changes in renal handling of glucose. In pregnancy, there is increased renal plasma flow. by about 30% over the pre-pregnancy value. That should be about 30% over the pregnancy value, from about 1.2 liters per minute to about 1.5 liters per minute. And this brings about increase in glomerular filtration rate by about 50%. So this increase in glomerular filtration rate brings about tends to affect the proximal tubule absorption of glucose. And when there is this affectation of proximal tubule this affectation of glucose absorption culminates in the renal threshold for sugar as glucose absorption being brought down from about 8.5 millimole per liter to from about 10 millimole per liter to about 8.8 millimole per liter. So you can see the pregnant woman leaking glucose in urine. So you have about 40 to 50% of pregnant women leaking glucose in urine as a result of all these mechanisms. So in pregnancy, there tends to be in about 50% nausea and vomiting, precipitating hypoglycemia. So hypoglycemia is more likely, especially for patients on insulin that is vomiting, that's having nausea and vomiting. So if appropriate measures are not taken, this patient goes into ketoacidosis and they tend to have a vicious cycle of insulin resistance. In pregnancy, there is increased infection with insulin resistance. There is increased infection, candidiasis, urinary tract infections, all of which make pregnancy diabetes control very, very difficult. In addition, in labor there is some work. Work is done in labor, so energy is expended, calorie is used. So if before labor the morning dose of insulin being taken is not skipped, patient tends to go into hypoglycemia. So we need to appreciate this area. Then postpartum, because the antagonistic hormone effect has been withdrawn, then there can be if care is not taken and the insulin dose is not reduced, not up postpartum, then a patient can go into hypoglycemia. Then secondly, in addition, postpartum during breastfeeding requires consumption of additional calories, in which by the time the patient the woman breastfeeds, then there is tendency for the woman to eat more, which can call for increased insulin dose. So what are the effects of diabetes on pregnancy? Generally, there is increased perinatal mortality. Neurologically, infants may be immature, hypotonic, poor suckling reflex that delays adequate feeding. Then, higher risk in offspring, later in life, there is higher risk of the offspring getting obese with some degree of glucose intolerance and metabolic syndrome. So, what are the effects of diabetes on pregnancy? Hyperglycemia is the central insult that is associated with increased risk of morbidity and mortality in pregnancy. Number one, there is increased risk of what major congenital malformation, and the primary insult is the hyperglycemic state. There is fetal macrosomia, resulting in increased there is fetal macrosomia, culminating in there is fetal macrosomia. In diabetes mellitus, there is this differential growth because insulin, there is this in diabetes mellitus, in DME in pregnancy. What is the pathophysiology. What is the pathophysiology behind the pathology of fetal macrosomia? There is this hypothesis we call Patterson hypothesis, which states that maternal hyperglycemia results in fetal hyperglycemia. Glucose is transferred to the fetus by facilitated diffusion. So when there is high glucose level in the mother, this tends to increase the rate of facilitated diffusion, this precipitating in hyperglycemia in the fetus. And in the fetus, the pancreas of the fetus is functioning. So the fetal cell, the fetal pancreatic cells respond to the hyperglycemia by increasing insulin release, resulting in fetal hyperinsulinemia. Hyperinsulinemia is now the primary factor, aside from all other metabolic fuels being migrated from maternal circulation, like free fatty acids and the likes. So this hyperinsulinemia is an important growth. Insulin is an important growth factor in the fetus. And what does insulin do? Insulin, being an anabolic hormone, it affects differential peripheral growth in the liver, in the muscle cells, in the bones, sparing the head and the brain, because insulin doesn't have effect on glucose entry to the brain. So what happens to the fetus? There is asymmetric growth in which the trunk becomes much bigger than the head, because the head is going at the normal rate, while the trunk is going at an abnormal rate, so culminating in asymmetric growth. So this asymmetric growth during labor could result in several pelvic disproportion, warranting cesarean section. So even bad trauma. And what is the characteristic bad trauma? The characteristic bad trauma is shoulder dystocia, because insulin produces brain sparing effect with larger trunk. So shoulder becomes much wider and bigger than the brain, because the insulin does not have effect on brain growth. So the baby is prone to shoulder dystocia following the delivery of the head. Then in poorly controlled diabetes with vasculopathy, there can be intrauterine growth restriction. So other neonatal metabolic complications, hypoglycemia, hyperbilirubinemia, hypocalcemia, they are all the corollaries of fetal hyperglycemia resulting from maternal hyperglycemia. For example, what is the pathophysiology of the hypoglycemia? The fetus in utero is in the milieu of hypoglycemia with appropriate pancreatic response. So following delivery, the fetus is the fetus is taken away from the hyperglycemic milieu. So with the pancreas still functioning, the fetus is prone to hypoglycemia because the hyperglycemic source has been removed, while the pancreatic cells are still functioning. Then fetus is also prone to delayed fetal lung maturity from respiratory distress syndrome, which could be as a result of wet lung syndrome, early membrane disease, or aspiration disorder. Then there is this increased intrauterine fetal death from chronic hypoxia. So, what are other maternal complications? Other maternal complications include infections, as I've said earlier, preeclampsia, because of the large placenta area, vasculopathy, and the likes. Then polyhydramnios, because fetal hyperglycemia results in fetal polyuria. So with fetal polyuria, there is polyhydramnios. So preterm labor could be could be the effect of preeclampsia, over distension from polyhydramnios, even fetal distress. So there is this, they tend to have recurrent, diabetic patients may have recurrent spontaneous abortion because hyperglycemia is still an insult. Hyperglycemia is still an insult precipitating spontaneous abortion. Then there could be progression of diabetes-related chronic other complications. They are prone to ketoacidosis. There is intrapartum trauma. As I've explained earlier, and the threshold for cesarean section delivery is much lower in them. So in gestational diabetes mellitus, there is increased risk for development of type 2 diabetes later in life. In developed countries, the prevalence of diabetes in pregnancy is about 4%, with 88% of this being accounted for by gestational diabetes. In Nigeria, the average prevalence rate is about 1.7%, with gestational being carrying about 61%. Among the pre-gestational group, type 2 is the commonest. So what are the risk factors for gestational diabetes? Obesity with pregnancy weight of more than 90 kilograms, body mass index of greater than or equal to 30 kilograms per meter squared, family history of diabetes mellitus, previous delivery of microscopic baby, previous unexplained intrauterine fetal death, previous fetal congenital abnormality. So, having known those basic facts, how do we go about managing hyperglycemia in pregnancy? Management of hyperglycemia in pregnancy requires a multidisciplinary approach that should be tackled in the context of comprehensive maternity care. So what are the components of comprehensive maternity care? Preconception care, antenatal care, intrapartum care, and postpartum care. So management essentially requires multidisciplinary approach in the context of preconception, antenatal, intrapartum, and postpartum care. The multidisciplinary approach involves the following lines of experts. Obstetrician being the central figure, diabetologist, dietitian, health educators, diabetic nurses and midwives, and even social workers. Preconception care role can never be overemphasized. It gives a better pregnancy outcome in diabetes in pregnancy. Counseling on healthy weight management, diet, exercise, alcohol, cigarette, and smoking reduction. The preconception care brings about glycemic control, stabilization before the patient engages on the voyage of pregnancy. And this is the time that contraception can be is ensured, so that there is time for glucose stabilization before the pregnancy proper. So there is also a time to evaluate all that coexisting pre-pregnancy or medical conditions. Antenatal care. What does antenatal care entail? Early booking is key. During booking, there is detailed history reflecting patient biodata, last menstrual period to be able to date the pregnancy, duration of diabetes mellitus, if it is pre-gestational, comprehensive obstetric history, pre-existing maternal complications, family and social history. And there should be detailed general and physical examination because diabetes mellitus is a pan-systemic problem. You should be looking for signs of vascular, neurological, musculoskeletal, and obstetric complications. And other ancillary investigations should be done aside from making a diagnosis of what? Of hyperglycemia. So, if everything goes on well, patient is seen every 2 weeks, up to 32 weeks, then weekly thereafter, up to delivery. Antenatal supervision, assessment of fetal well-being. Periodic growth assessment 2 to 4 weeks, starting from second trimester, clinical and sonographic assessment should be done. Then there should be fetal kick count, cathodrography, and of fetal biophysical profile according to the local protocol. Timing and mode of delivery. How do we conduct that? Maternal hyperglycemia and macrosomia are associated with increased risk of intrauterine fetal death and other adverse outcomes. Spontaneous vaginal delivery is the goal in DM, and induction of labor may be considered at 38-39 weeks of pregnancy, or generally pregnancy or no condition should pregnancy be allowed to go beyond the expected date of delivery. Consideration may be given to elective cesarean section when the best estimate of fetal weight exceeds 4 kilograms. I repeat, consideration should be given to elective cesarean section when the best estimate of fetal weight exceeds 4 kilograms because of the problem of asymmetric fetal growth, precipitating shoulder dystocia, as I've explained. Then, fetal long maturity testing if delivery is anticipated before 38 weeks. Blood glucose control could be in form of measuring glycosylated hemoglobin, self-monitoring of blood glucose, or continuous glucose monitoring. There is no evidence to support any specific frequency of monitoring, whether 2 point, 4 point, 6 point, 7 point sugar test. However, 4 point sugar test is one of the commonest insulin regimen in this environment. So self-monitoring of glucose is recommended for all pregnant women with diabetes at least once daily, at least, irrespective of the local protocol. So with documented relation to timing of delivery. So for a patient on therapy, what are the targets of therapy? What are the targets of control? The main goal for treatment of diabetes in pregnancy or GDM is to prevent adverse effects on either the mother or the fetus. So, glucose control should aim at which values? Fasting glucose of less than 5.3 millimole per liter, 1 hour postprandial glucose of less than 7.8 millimole per liter, or and 2 hour postprandial glucose of less than 6.7 millimole per liter. And patient needs to be educated to recognize and treat signs of hypoglycemia. So it becomes essential for the family members to be carried along in this respect, and patient must be taught, and the patient, not only the patient, all the family members must be taught how to use glucometer. So the target of glucose control during labor and delivery should be between 4 to 6 millimole per liter. So, what is the general approach to glycemic control? General approach to glycemic control is a step ladder thing. 1, lifestyle modification, which aims at what? The appropriate diet, giving the appropriate diet and exercise. Drug, the use of metformin and glyburide. There's evidence for the use of metformin and glyburide in the treatment of diabetes in pregnancy, and results have been obtained. So when metformin or glyburide is failing and target could not be obtained, then insulin is added. So what is how do we go about the dietary control and exercise? Generally, caloric intake should be between 1,800 to 2,000 calories per day, which is about 30 to 35 calories per kilogram of ideal body weight per day. So the carbohydrate being taken should be about 200 grams to supply about 50% of the total calories. Fat being taken should be about 60 grams to provide 30% of the total calories. While protein being taken should be about 100 grams to provide 20% of the total calories. So, and there should be, in terms of exercise, there should be programs of moderate physical exercise. Rigorous exercise is not advised in pregnancy. So what are the forms of physical exercise advised? Walking, even or swimming. Walking or swimming could be fantastic. So use of drugs, metformin or glyburide. The use of metformin or glyburide has been considered by several organizations. Metformin use is becoming more popular than glyburide. When blood glucose target cannot be reached by diet and metformin or glyburide, insulin is required. Metformin is a biguanide, and glyburide is the second generation sulfonylurea. So, insulin therapy. Indication for use of insulin. Insulin should be considered as the first-line treatment in women with gestational diabetes mellitus who are at risk of failing on oral hypoglycemic drug therapy. So, who are those patients that are at risk of having oral hypoglycemic therapy failed? So this is a particular set that insulin should be commenced with ab initio. So what are the various what are the subset of the group? Any patient in whom diabetes is being diagnosed in less than 20 weeks gestational age is a candidate for insulin therapy. If there is need for pharmacologic therapy more than 30 weeks, the patient should be commenced on insulin. Then when the fasting blood glucose of more than 6.1 millimole per liter is recorded, then insulin should be the first line drug. Or when there is 1 hour postprandial glucose of greater than 7.7 millimole per liter, insulin should be the first line drug. And finally, when the pre-pregnancy weight gain has exceeded 12 kilograms, in that, when pregnancy weight gain has exceeded 12 kilograms in that index pregnancy, then the patient is a candidate for insulin therapy. So, insulin therapy is indicated for all women with pre-gestational diabetes, no matter how low the dose is. Any patient with gestational diabetes is a candidate for insulin therapy ab initio. Most commonly used treatment when dietary therapy fails to maintain blood glucose level at desired ranges in GDM is also what? Insulin. So, what are the various forms of insulin? But generally, human insulin is recommended because human insulin is less antigenic than bovine or porcine. So, which dose should we use? Dose and type of insulin used are dependent upon the specific abnormality of blood glucose noted during the monitoring. So, regimens of injection be two injections per day, 3 injections per day, 4 injections per day. However, there is no evidence supporting a particular frequency of insulin being given per day. No evidence that it should be 2 injections, 3 injections, 4 injections. What one does depends on the need of the patient in question and on the local protocol and what the results that are being obtained are in the environment in question. So, insulin resistance increases as I've said earlier, insulin resistance increases as pregnancy increases. So, type and dose of insulin are tailored to meet the patient's requirements. So, there should be adjustment in the insulin dose based on the point sugar test, whether it is 2-point sugar test, 3-point sugar test, 4-point sugar test, 6-point sugar test. Adjustment of insulin is based on the values obtained. Ideally, insulin dose should be the adjustment should be the adjustment should be over 2 to 3 day interval. However, if there is no consistent pattern in sugar values, then 2 to 3 days intervals could be prolonged for a more objective adjustment. Insulin regimen and dose. How do you know the appropriate dose to give? Calculation of insulin dose is based on expected weight and gestational age, but it could be modified according to the lifestyle and self-monitoring of blood glucose. So, generally, there is this formula based on trimester in question. The first trimester, insulin requirement usually is between 0.6 international unit per kilogram of the current body weight. When insulin is required in second semester, a dose of 0.7 international units per kilogram is given. When insulin is required in third semester, a dose of 0.9 international units per kilogram is given. However, it might be prudent to go lower and to be able to be flexible with all these insulin dosages for fear of hypoglycemia. How do we conduct intrapartum management? Usual dose of intermediate acting insulin is given at bedtime and in the morning of delivery. Insulin is withheld for fear of hypoglycemia. So intravenous infusion of insulin in normal saline is begun at about 1 international unit per hour. If initial blood glucose is 4 to 6 millimole per liter, and the target of blood glucose in labor should be 4 to 6 millimole per liter. However, if blood glucose is less than 4 millimole per liter, then insulin infusion, if the infusion rate is halved to about 0.5 units per hour, and if the glucose value is more than 6, then the insulin infusion dose is doubled. If blood glucose is between 4 and 6 millimole per liter, which is the target expected, so no change in insulin dose is required. Of course, there should be pathographic monitoring of labor with continuous electronic fetal monitoring. So postpartum management. There should be strict care and observation of baby for hypoglycemia, polycythemia, hyperbilirubinemia, with appropriate special care baby unit management in case of any abnormality. Maternal insulin requirements drop appreciably, usually to about half postpartum, because the diabetogenic hormone effects have been withdrawn. So most gestational diabetes, most patients with gestational diabetes will not require further insulin therapy. And of course, breastfeeding is encouraged, and contraception should be there should be appropriate and intensive counseling on contraception. And sterilization is usually advised after having 2 babies, because the subsequent pregnancy tend to be more turbulent than the previous ones in patients with diabetes, especially those that are manifesting diabetes in pregnancy. Then, if with well-controlled glucose, the other contraceptive options include mini pills, depo-provera, and IUCD. Thorough counseling for appropriate preconception care or follow-up should be given, and diabetic mothers should be followed up. The major challenge with diabetic mothers, especially in developing countries, is they are lost to follow-up. And it has been identified that one of the ways to actually identify them, to catch them, is to follow them to baby welfare clinic, in which the appreciable number of them could be caught and being followed up appropriately. So pre-gestational diabetes always requires resumption of insulin following delivery, because patient has already been on insulin before pregnancy, and there is need to monitor blood glucose very well. Recalculation of insulin and diabetic requirement is key. I want to emphasize a fact that almost 98% of women with gestational diabetes will revert to normal glycemia after delivery. I repeat, almost 98% of women with gestational diabetes will revert to normal glycemia after delivery. But there is increased risk of future gestational diabetes and diabetes mellitus. People are talking about in 20 to 40 years' time, appreciable segment of them will come down with diabetes mellitus. Probability that diabetes will recur in each subsequent pregnancy is also as high as 90%. Therefore, a patient with history of diabetes in the period of pregnancy should be screened again in the index pregnancy. Higher maternal pre-pregnancy weight is found to be what? Is also found to be a predictor of recurrence of gestational diabetes. A 75-gram oral glucose tolerance test should be performed 6 weeks postpartum, and in most cases the values are normal in gestational diabetes. So postpartum too, this is also a time to intensify and to work on patient lifestyle modification, like weight loss in those that are overweight. In conclusion, diabetes mellitus is the commonest endocrine disease in pregnancy. There is high prenatal and neonatal morbidity and mortality with poor control. The importance of strict pre-pregnancy, antenatal and intrapartum and postpartum control of sugar cannot be overemphasized. So I want us to appreciate, even if it's going to be to a little extent, other endocrine disorders of interest. What are other endocrine disorders of interest? Thyroid disease in pregnancy, pituitary disease in pregnancy, adrenal disease in pregnancy. So thyroid disease is one of the commonest endocrine disorders in pregnancy. Therefore, it is of great obsessive importance. Generally, thyroid hormones T4 and T3 are synthesized within the thyroid follicles. Pregnancy has a significant impact on normal thyroid physiology. And in pregnancy, there is this increased thyroid binding globulin primarily by estrogen stimulation. And this brings about increase in total thyroxine, T3 and T4. But circulating free thyroid hormones concentration are constant. It is the total T4 and T3 that is increased. However, the free T4 and T3 concentrations are relatively constant. So, and there is, because of the increased glomerular filtration rate and renal plasma flow, there is this increased iodide loss in urine, which could precipitate hypothyroidism in some other conditions. Then, thyroid gland tends to increase in size, and there is increase in thyroid stimulating hormone. Maternal hyperthyroidism is about the commonest variants of thyroid disorders in pregnancy, occurring in about 1 in every 500 pregnancies. Majority predate pregnancies, and 90% of these are as a result of Graves' disease, which is essentially autoimmune disorder associated with thyroid stimulating antibodies. Other rare causes include toxic nodules, Hashimoto thyroiditis, multiple nodular goiter, and rarely gestational trophoblastic disease. Clinical features of maternal hyperthyroidism could be confused with normal pregnancy symptoms. And what are the symptoms? Neck swelling, weight loss, palpitation, hyperphagia, excessive eating, abdominal pains, vomiting and diarrhea, heart murmurs, heat intolerance could be there. There might be mild maternal tachycardia, arrhythmias, even with fetal goiter, because a thyroid stimulating hormone can cross the placenta. So, but the diagnosis is key. But diagnosis could be difficult using clinical features from history and examination because of the aforementioned reason. So, diagnosis is confirmed by assessing by appreciating high levels of free T4, free T3, and low level of thyroid stimulating hormone. I repeat, diagnosis is confirmed by appreciating high levels of free T4, free T3, and low level of thyroid stimulating hormone. So, what is the treatment like? The aim of treatment is to maintain free T3 and free T4 in the high normal range in order not to precipitate hypothyroidism, which effect could be more grave than what you're actually treating. So, one of the commonest drugs being used is carbimazole. And carbimazole essentially is relatively safe in pregnancy, but the lowest dose should be used. And what is the lowest dose? A dose of less than or equal to 15 milligrams in divided dose must be used in order to, because Carbon also can cross can cross to the fetal circulation, precipitating hypothyroidism. So, and following delivery, carbimazole can still be secreted in breast milk, and monitoring of thyroid function is essential. So, propitioracid is another drug that can be used, but the use should be with caution, even more caution than carbimazole, because the rate of secretion or crossing is more with propitioracid compared to carbimazole, and the lowest dose possible should be used. And what is the lowest dose? 150 milligram in divided doses, because as I've said, it causes placenta. It's also what's secreted in breast milk. I want you to appreciate the fact that radioactive iodine is contraindicated in pregnancy for fear of hypothyroidism and the future development of thyroid carcinoma in the fetus. So surgery may also be needed, but it is best done pre-pregnancy. So what are maternal complications of hypothyroidism? Intrauterine growth restriction, fetal distress, preterm labor or birth, stillbirth, thyroid storm, and maternal death. So we should know some things about maternal hypothyroidism. Maternal hypothyroidism is the commonest the commonest cause of maternal hypothyroidism is iodine deficiency. And maternal iodine deficiency is also associated with the development of cretinism in the newborn due to congenital hypothyroidism. Over-treated hypothyroidism could be a cause also, especially treatment with radioactive iodine. So serial thyroid function is key. Treatment is with full thyroid replacement in pregnancy, and prognosis-wise, postnatal depression, you have postnatal depression in some, and 20% will remain hypothyroid postpartum. Pituitary disease. The commonest variant of pituitary disease in pregnancy is hyperprolactinemia. Although it is an important cause of infertility and amenorrhea, which may prevent pregnancy. However, patients get pregnant with hyperprolactinemia, and hyperprolactinemia could constitute a problem in pregnancy. So what are we saying? It may coexist with pregnancy. So what are the causes of hyperprolactinemia? The commonest cause is pituitary adenomas in most cases. Adenomas less than 10 millimeter in diameter. So other causes include drugs like dopamine agonists like metidopa, phenothiazines. What are the clinical features of hyperprolactinemia? Visual disturbance, which usually bitemporal field loss in nature, recurrent headache, and milky breast discharge. How is diagnosis made? Diagnosis is made by a combination of prolactin level and computerized tomography scanning of the pituitary fossa. Prolactin level, diagnosis by prolactin level is not reliable, because in normal pregnancy there tends to be the prolactin level can increase 20-fold. So for this to be more objective, prolactin concentration value is combined with computerized tomography and scanning of the pituitary fossa, and the visual field check should be done continuously. So what is treatment like? The drug of choice is the dopamine agonist, and the dopamine agonist including bromocriptine, newer drugs like cabergoline and quinabolide. Newer drugs like cabergoline and quinabolide, they are longer acting than bromocriptine with less side effects. Then there will be a need for what? For surgery and radiotherapy. There will be a need for surgery and radiotherapy, which are best carried out before pregnancy. Adrenal disease. All adrenal diseases are rare in pregnancy, but one of the commonest adrenal disorders in pregnancy is Cushing syndrome. It's a condition of increased glucocorticoid secretion, usually as a result of hypersecretion of adrenocorticotropic hormone from a pituitary tumor. Most women with this condition are infertile, but among the infertile, some of them will still get pregnant, and the condition tends to coexist with pregnancy. Those that are pregnant, they have increased incidence of preterm delivery and stillbirth. Diagnosis may be difficult as the syndrome mimics pregnancy symptoms and signs. What are the signs? Striae, weight gain, weakness, hypotension, impaired glucose tolerance. If suspected, cortisol levels should be assessed with adrenal imaging done with computerized tomography and magnetic resonance imaging. Addison's disease. Addison's disease, otherwise known as adrenal insufficiency, is usually as a result of an autoimmune process. And what are the clinical features? Feelings of exhaustion, nausea, hypotension, hypoglycemia, weight loss, adrenal crisis. Diagnosis may be difficult as cortisol level may be firstly low or be in the low normal range due to the physiological increase in cortisol binding globulin in pregnancy, which is giving a false impression of appreciable level of cortisol. So treatment is essentially by fluid replacement and glucocorticoid administration. Pheochromocytoma. Pheochromocytoma is a rare catecholamine-producing tumor in pregnancy. It arises from the adrenal medulla in 90% of cases. It is important in pregnancy as it may present with hypertensive crisis, and most of the symptoms are confused with symptoms of hypertensive disorder in pregnancy. Pregnancy is hypertension, even preeclampsia, even at times eclampsia. Pheochromocytoma is diagnosed by assaying for 24-hour measurement of catecholamines and their metabolites. Treatment essentially is by the use of phentolamine, which is an alpha blockage drug. Cesarean section is the preferred mode of delivery as it reduces the risk of sudden catecholamine surge associated with vaginal delivery. These are my references. Thank you.